All right, so here in this video, we're going to go over some strength breakouts that we're going to use to target hip abduction. Now, this is another example where I think we want to keep things as simple as we can. And all of the exercises that we're going to show here, or at least I'm sure the majority of the exercises, are things that you've probably seen before. But the real key here is that we need to be very focused on form with these exercises, and we need to be very picky and specific about making sure the patient or the client is feeling the things that they're supposed to feel and feeling contraction where they're supposed to have the contraction. Now, to understand this, we need to keep in mind that there's really three main muscles that are going to provide hip abduction. These are going to be your gluteus medius and minimus, and they're also going to be your TFL. Now, in the vast majority of cases, the overwhelming majority of cases, it's the gluteal group that we're trying to target here. This is the area that seems to be weak and dysfunctional and is inhibited in just so many patients. And oftentimes what we'll find is when this occurs, the body is going to really rely on that TFL muscle. In other words, this TFL is going to be a very common compensator in terms of force production with hip abduction. And this tendency to compensate and tendency to drive abduction through the TFL over the gluteal group is going to also bleed into the exercises as well if we're not careful and we're not specific and picky with how this is happening. So as we go through the exercises, we're going to also talk about how to ensure this proper form, and we're going to go over some of the really key things that we need to make sure the patients are feeling in order to make sure these exercises are targeting the right group, which in this case is going to be that gluteal group that we've talked about. All right, so the first exercise we're going to review is just going to be our basic sideline hip abduction exercise. This is just a basic leg lift, but we're going to be sure to drive the motion from not only the hip itself, but from that gluteal group like we talked about. So when we're doing this, we're just going to lay on our side, and in this case, I'm just going to use my hand for support, but it would certainly not be a bad idea to use a pillow or a yoga block for support here for the head as needed. And what we're going to do here is typically get in this position where we want our lower leg bent for support. And then what we're going to do is simply lift our leg into the air. But this lift is where we need to be really picky with the form. And there's a few really critical compensations that are going to happen here, especially in the presence of a dysfunctional gluteal group like we just talked about. So first off, when we lift, we want to make sure we're lifting straight up. When that TFL is dominant, the tendency is going to often be to lift and bring the leg forward to get more of that hip flexion. Or sometimes what will happen is the pelvis will also rock backwards. And again, this creates that relative flexed position. And this is an indication that we're getting more force production and more muscle contraction from that TFL group as opposed to the gluteal group that we're trying to target. The other thing that we're going to very commonly see is that as we lift up, that hip is going to kind of rotate outwards. And again, this is a sign that we're trying to avoid, or a compensation we're trying to avoid. It's typically easier for the patient or more effective for the patient if we give them the cue that they're trying to lift the leg up, but they're trying to almost like lift the heel up and keep that foot relatively level as opposed to allowing that torque. The other compensation that we want to be mindful of is compensating through the trunk here. So the idea is we want to lift from the hip. We don't necessarily want to crunch up and feel it all in this abdominal group. Now, sometimes avoiding this altogether is difficult, and it's not that we don't want these muscles to be on and stabilize. We just want to make sure that the majority of effort and motion and muscle contraction feeling is coming from that hip itself. Now, often what we will do to help ensure with form is we're going to get the patient to do this kind of sitting back close to a wall. And this way, what they can do is as they're kind of positioning, they can keep their heel back on the wall. And this slight backwards or extended hip position is going to really help prevent that sliding forward or that flex position. And it helps to get a little bit more of engagement through that back gluteal group, that G-med and G-min like we talked about. So ensuring that proper setup, the patient's simply going to let the heel come down, and then we're going to slide it up the wall, keeping it level as we discussed. And what they're typically going to find is at first it's not overly difficult, but as we lift up higher and higher towards that end range, they're going to really feel these muscles contract on the outside of the hip. Specifically, we want them to feel it not on the front and not exactly on the side, but kind of on that posterior lateral corner where that gluteal group lives. So we're simply going to have them come up high as they can. We really want to hold this top position for a couple of seconds to really feel that muscle contraction. And then they're just going to let it slowly come back down. And then we're going to go back up. Up as high as we can, really trying to feel that muscle contract. Let it slowly come back down. Now, the other thing we'll just briefly talk about here is the programming itself. This would be the sets and reps that we're going to prescribe. Now, keep in mind that in the vast majority of cases, we're trying to use this to build strength and endurance of this gluteal group. So this is another example where we want patients to work hard and work to fatigue, but we want to make sure we're ensuring adequate rest. So typical prescription here is going to be to perform 3 to 5 sets. We're going to do this once during a day, but we're typically going to only do this 2 to 3 days a week to make sure we're allowing that recovery time in between sessions. Now, the other thing to keep in mind is the number of repetitions that they're doing. Now, this is another example where we want to make sure that we're working hard enough, but that the exercise is still doable and we can do it with good form. So what we will typically do is shoot for 3 to 5 sets of 10. But when I say 10, we want this to really be sets to fatigue around 10. And so what I mean by that is if the patient is really only able to do, 2 or 3 or 4 or 5 repetitions, it's an indication that the exercise is too challenging and it's not going to provide us the results that we want. And in this case, we're going to have to regress the exercise, which we'll go over an option for in just a moment. Likewise, if we're suggesting sets of 10, but the patient is able to go to 12 or 13 or 15 repetitions, I'm going to have them go to those higher level or higher number of repetitions in order to fatigue the muscle. And what we'll typically find is once we're able, or once the patient is able to get into these higher number of repetitions, we're then ready to progress the exercise into a more challenging level, which again, we'll go over in some subsequent videos in just a moment. All right, so we started with our basic leg lift or our basic hip abduction wall slide. But if this is a little bit too difficult or challenging for the patient, we can also use this regression, which is going to be simply to do an isometric hold with the hip in an abducted position. So again, we'll have a very similar setup in that we're on our side, support the head as needed. But here what I'm going to do is just get my leg up resting, or I should say we'll get the patient's leg up just resting on something. So the leg is kind of passively positioned into this hip abduction position. Just as we talked about in the previous video, we do want to be picky with form here. We want the leg right underneath our body, so maybe even slightly behind, to make sure that we're going to target that gluteal group as we discussed. And from here, I'm simply going to have the patient slowly just do a little lift off. So we're not lifting very high, just enough to slide a hand under our foot, but it's just enough that the foot becomes and the leg becomes unsupported. So in this supported position, there's little to no muscle demand or activity needed here. But with this little lift position, it's just enough to start to engage that muscle group. But this is going to be an easier exercise because it limits the range and it really focuses just on a little bit of contraction in this abducted position. And what we can do is use this as a segue into, or a segue to build into or progress into our basic hip abduction exercise if that's a little bit too difficult to start. So again, just laying on our side, slight little leg lift up, hold, come on back down. Now in terms of exercise prescription, again, we're typically going to try to have patients hold this for 10-second holds, and we're going to do 6 to 10 repetitions. So this is kind of like a minute's worth of contraction or a minute and a half worth of contraction. Now, the idea here, though, has to be good quality. So as we're lifting, we said 10 seconds is the target, but if that muscle gets really weak or shaky, or the hold just becomes too difficult after 5 or 6 or 7 seconds, then 5 or 6 or 7 seconds can be the number. Same thing with repetitions. If we're shooting for 6 to 10, it gets really tight and weak around 4 or 5, then that might have to be the starting number. But we are also going to have patients keep track of these numbers, and we can help to use the progress or lack of progress, for that matter, as a gauge to whether or not the exercise is effective and whether or not we need to change the exercise, or as the exercise becomes too easy and they're able to meet those number targets, we are then able to progress the exercise to something more challenging. All right, so the next progression that we're going to go over is our wall ball. Now, just as a quick note, I do find this exercise much easier and much more effective if someone actually does have access to one of these exercise balls, but it's not absolutely necessary. We can do it without. So let's go over how we do this with the ball itself, and then I'll just briefly go over a couple little changes that we need to make if there's no access to an exercise ball and we need to do it without. Now, the other thing to keep in mind is that this is a fairly difficult progression, but it's a very important one. One of the really big deals here is that as we're using this progression, we're transitioning from a non-weight bearing position to a weight bearing position. And why this is so critical is that really it's in weight bearing with things like walking and running that these muscles need to function properly. So this is an example where it's not only important just to have strength and adequate endurance of this muscle, but we also need to be able to access that muscle, or the parts of your brain responsible for moving and contracting your body need to have access to this muscle when we're in a more upright standing position. So this not only makes it a progression in terms of difficulty for the muscle itself, but it's also a bit of a motor control or a coordination progression as well, which is why it's so critical. And this is really one of the key points we're trying to get to with all of our patients that we're trying to develop strength in this hip abduction or lateral gluteal muscle group. So what we're going to do is get our ball. And of course we have the trochanters on the side, and we really want to get the trochanter right into the ball here. So we're just standing beside the ball against the wall. Is what most people do is they're going to want to really lean into the ball. And we don't really want that. We want the body to be a little bit more upright. I almost like it so we're trying to get the foot in a little farther than we think to, almost the point where we're straight up, or even where the ball is actually pushing us to the side a little bit. And from here, we're also going to think about holding on to the wall just for a little bit of support. We're less concerned with balance here. We're more concerned with proper activation from this standing position. Now, when we are in this position, we do want to make sure we stay tall. And what you'll often find is in order to get that proper activation of the gluteal group over that TFL group, we need to perform a little tiny standing pelvic tilt. This just ever so slightly starts to change the alignment around that lumbopelvic hip area, and it just makes it a little bit easier to gain activation here. So from here, I'm keeping my stance leg, my outside leg right on the ground, and I'm just going to lift the leg closest to the ball off the floor. It doesn't matter where we lift, we're simply going from a two-leg stance to a single leg stance. And now from here, I'm just going to slightly push into the ball. I'm just trying to lean in, create a little bit of pressure, and then I'm trying to lift that ball up the wall. It's not going to lift very high, only an inch or two, but as I lift, I should really feel those lateral gluteal muscles tense and contract to generate that motion. And that's the other key. We're trying to kind of tilt the pelvis laterally to roll the ball up the wall, but the motion is coming from the muscles on the outside of that stance hip. And this is something a lot of patients won't really understand. They'll think they're trying to kind of lift from the trunk muscles here, but we need to be really clear when we're explaining this and prescribing this to patients about how we're trying to drive that motion from that outside stance hip. Again, as we've talked about in the introduction and with some of the subsequent videos, we need to make sure it's that back half of the hip where that gluteal muscle group lives that's driving the motion as opposed to those muscles into the front, that TFL group. Now, as I mentioned previously, the ball does work really well, and I try to encourage people to use the ball whenever possible. But if that's just not an option, we can do the same thing freestanding. By the way, as a side note, if I am going to prescribe this freestanding, I almost always will show people with the ball in my office first to get the form down, and then make sure they can replicate that same feeling of muscle contraction without the ball. So in this case, we want to just stand close enough to a wall that we can have some support, slight little pelvic tilt in order to just kind of line up that lumbopelvic region the way we want it to. And then I'm just going to lift that sort of leg closest to the wall off the floor. And then from here, I'm just hiking that hip up. But again, as I've shown people this in my office, I'm having them imagine that they're lifting or rolling that ball up the wall. And we still need to be really critical to feel that same muscle group, that posterior lateral side of the hip contract. Hold for a second or two, let it slowly come back down. Again, slowly, so we can train that eccentric portion. So if we don't have a ball, this is a fair substitute, but like I said, at least show people with the ball so they get the concept and get the mechanics, and make sure that they're feeling it in the right spot so that we're not training the wrong muscle group or we're not getting the effects that we want. All right, so this last and final progression that we're going to show is going to be combining this wall ball position and this activation of the lateral hip with a partial single leg squat. Now, for the most case, as we've talked about in past sections and past videos, a lot of what we're trying to do here is really focus on local segmental function. Now, that's not to say that integrated function and whole body multi-joint movements are not important. Of course they are. But as we've talked about in previous videos, if the local segments aren't working well in and of themselves, then they're going to have trouble working properly when combined with multi-joint functional movements, right? So that's why we really focus on first engaging and correcting local function in order to kind of get the patient where we need to get them. But there are some cases where we need to be picky about integrating this corrected local joint motion and local muscle function into the rest of the kinetic chain. And this is one of those examples. So what we'll often see when we have these gluteal muscle groups is, when we have this weakness or dysfunction in this gluteal muscle group, is we'll see a lack of control of the limb when we're doing things like one leg squats and one leg lunges. So obviously when that's the case and there's subsequent weakness that we find in this hip group that we've talked about, we need to correct that local function. But sometimes just correcting that local function doesn't necessarily translate into the movement pattern changing. And if that's the case, we need to do an extra step in order to kind of put the pieces back together, so to speak. So how we're going to do this is going to be just a little bit of an addition to the general wall ball exercise. So this part is going to be the exact same setup as we discussed in the previous section. We're going to kind of get our ball against the wall. We're going to lean in. We're holding, slight little pelvic tilt. And then from here, I'm going to slide that ball up the wall. Now, at this point, when we're prescribing this exercise, this should be second nature to the patient or to the client. So this part should be simple and straightforward. We've got that activation here. Our hip is staying kind of level or maybe even a little bit biased towards this tilted position. Now what I'm going to do here is I'm going to hold this pressure in my hip, hold the pressure against the ball, and now I can start to kind of go down into that one leg squat. So the idea here is almost like an isometric hold into that lateral part of the hip and into that glute med and glute min. And then I'm holding that isometric contraction as I'm kind of dropping down and as I'm coming back up. And what this is really going to do is hold the tension in that muscle as the knee and the ankle bend and the hip bend slightly into flexion. So this is integrating the contraction and the hold here with the bending of the rest of the limb. It's a more complicated task for the nervous system to do, but it's an important one because of so many one-leg activities that we're going to do with walking and running and single leg squats and lunges and so on and so forth. if it doesn't correct itself just with strengthening these muscles, we need to add this last and final step just to kind of tie everything together.